the last speaker of this session is going to be David Chambers. He's Deputy Director for Implementation Sciences, the National Cancer Institute, National Institute of Health, and before his arrival at the NIH, he worked as a member of a research team here in Oxford. He's going to talk about the drivers of overdiagnosis through the lens of implementation science.
Okay, wonderful. Well, this was not necessarily how I expected to start the day, being over here instead of with all of you, but I'm incredibly grateful to the conference for figuring out a way in which I can, back here in the States, join you remotely. It's 4:44 a.m., so whether anything comes out of my mouth is intelligent, maybe related to time zone or maybe related to what I prepared for you. But what I wanted to do is just take a few minutes and walk you through some of the lenses that we think of when we talk about implementation science and de-implementation of low-value care and how that might be helpful as we think about the challenge of reducing overdiagnosis. You see the DPhil letters next to my name. It is particularly difficult for me not to be with you in person because I spent an incredible time, a number of years, in Oxford, and it really shaped everything that I think that I'm going to share with you today. And in fact, on that note, so when I was in Oxford, this was from 1996, 97 to 2001, it was prior to this idea of this sort of systematized way of thinking and studying implementation science. So this was in this pre-implementation science phase. I came over there as a doctoral student to study organizational behavior in healthcare, social science that was mentioned a bit before, looking at cultures of organizations, organizational theory, how we try and change, improve healthcare to the extent possible. It was a very exciting time, certainly in Oxford with David Sackett and others. There was this recognition of evidence-based medicine as this opportunity to really think about optimizing. And I think this was mentioned before, but it's important for me to reflect on how evidence-based medicine was defined at that point and how it still occurs to me. It is this confluence of factors around the evidence from the research that we do, the clinical, the system-level expertise, and then the preferences of patients, families, and systems, et cetera. Too often, evidence-based medicine gets reduced to just that evidence part of the equation. But I feel like folks had it right when they talked about how it was really about how these different important forces work in harmony. I had this incredible opportunity with Sue Dobson, who's still at Oxford, and others, to, at this time when evidence-based medicine was being seen as a way to truly improve care. There wasn't any challenges, of course. There were a number of different NHS projects, a number of different projects in England and in Wales that we had a chance to look at. Often it was this notion of we have the evidence and all we really need to do is share that evidence within our systems and everything will be fine. Similar at the time in the US, there were a number of these evidence-based practice centers that the then Agency for Healthcare Policy and Research had funded, all around trying to identify where are areas of medicine where we're not doing as well as we should. How do we synthesize the evidence? How do we disseminate that evidence, and how do we then see incredible improvement? Out of this, you see this tome that is in the Bodleian Library, a couple blocks away from you. It added 1 to millions of volumes, but it gave me this foundation for really thinking about the complexity of trying to improve care, of trying to implement what we know works, and ideally trying to reduce the use of things that we know do not. So again, just another way of underscoring how hard it is for me not to be with you in person because this was transformative. When I got back to the US in 2000 and 2001, we were really confronted with this challenge that so much of the end product of our research was deemed to be the publication. And so Baylis and Boren back in 2000, so now 25 years ago, looked systematically at what happens if we assume that the pathway to getting evidence implemented is the publication. And so what they showed very nicely was that there's all these different steps that take a certain amount of time. You see that on the right. And there's all of these different ways in which we lose the valuable evidence. We lose the valuable findings that should be improving practice, but are not necessarily. What people may be more familiar with was this tagline that emerged from this work. And this tagline basically said that it takes 17 years to turn this fraction of original research into the benefit of patient care, that we're taking way too long to do way too little with all of the research that we've created. And so this really encouraged a lot of folks in this newly defined, whether it was translating research into practice or implementation research, implementation science, to try and say we need to do better. And often the idea was that by doing better, the pathway to doing better is to do more. So when we started to think about the best way to encapsulate all that we were learning about implementation, and we actually saw a journal, we saw a set of researchers cluster around this notion of implementation science, where we're studying methods to promote how we integrate our evidence, our research findings, our interventions into healthcare policy and practice. We tried to lay out, and this is an infographic that we at the National Cancer Institute came up with a few years ago. What are the dimensions of the problem, or what are the dimensions of the solutions to trying to improve care? So we start in this case with all of these different innovations that we have, these wonderful discoveries that we think have some benefit for patient care. But we recognize that the challenges are not just, as we classically thought, that we just need to do more and more and more. In many cases, we have the overuse of innovations that are not actually benefiting those who receive them. We recognize within implementation science that this is a multi-level challenge, and certainly thinking about reduction of overdiagnosis is a multi-level challenge, that we think about factors at the individual, at the provider level, at the healthcare system level, at our broader community level, at the policy level. All of these are indicating both whether we can better implement effective interventions, but also whether we need to do less. Now, we focus in implementation science a lot on these strategies through which we can try to improve implementation. And so some of these things are the ways in which we're trying to work with key partners within healthcare systems and community settings to provide whatever assistance we can. How do we interpret the evidence? We think a lot about trying to adapt and tailor the evidence to particular circumstances, recognizing that rarely, even if something has an evidence-based label, is it a one-size-fits-all. We think about how we can try and better support our practitioners so as to make it easier for either doing more in some cases or doing less when overtreatment, overdiagnosis, overuse is apparent. And then we recognizing that this is a challenge on all sides, that we can't ignore the influence that our patients, our families have in terms of the demand, in terms of fear, et cetera. So when we think about implementation science, we're recognizing that there are these strategies, but we're also trying to think about what are some of the key outcomes. And again, in a lot of our research that we at the NIH and others fund, we jump over this question of how we know that implementation is successful. We predicate a lot of our work on a typical clinical trial idea where we have this innovation, we have this intervention, we enable it to be delivered in the context of a clinical trial, and then we see what happened at an individual level. But when we shift our attention to what is the intervention, to how do we make sure that that intervention is optimally implemented, we have some different outcomes, some really important outcomes that are also relevant if our goal is to try and reduce diagnosis, so overdiagnosis. So we need to think about whether the interventions, whether the diagnostic tests are acceptable. What level of uptake are we starting with? What are the costs, both of delivering new interventions, but also potentially the costs associated with any effort to try to remove them? We need to be thinking about the quality measures, whether our diagnostic tests are, as an example, being delivered as intended. And we need to not just think about the initial state of things, but what has to be maintained over time. It's not good to make an improvement that then doesn't last beyond the sort of active phase of a particular practice. So So in just framing implementation science, I hope that you'll find that there's some really nice corollaries to all that's already been discussed in the session that I've been listening to on YouTube, and all that will take place in addition over the coming days. So what I wanted to do also is just reflect on how we have many different frameworks that are associated with implementation science. There are hundreds at this point of frameworks that have been developed with this idea of giving a broad sense of what are the types of influences on care, and then how do they potentially drive our efforts to implement, to de-implement, et cetera. The Consolidated Framework for Implementation Research, which Laura Damschroeder and others within the Veterans Health Administration in the US had come up with, really consolidates multiple frameworks to recognize some of the key areas that underpin any of our decisions to deliver care. We recognize that there's a lot of determinants at the inner setting, at the local clinic level, within a hospital, et cetera. And that these characteristics are going to be affecting how well any change is going to take root. Not just at the inner setting, but we recognize there's a larger ecosystem that is also going to drive how well we're able to make any changes. The financing, external pressures, policies, and laws that in some cases may work in concert with trying to reduce overdiagnosis, in other cases are actually going to potentially get in the way. There's an incredibly important set of characteristics around the thing, as some folks have said, the thing that we're trying to implement, the innovation, the diagnostic test in this case, the relative advantage of a particular test versus others, the complexity of it versus something else that we might be doing, how much it costs to deliver, what are the incentives around delivery that may, as we just heard about, create some potential challenges, conflicts of interest in terms of who benefits from particular tests being delivered. At the individual level, back one of the first papers that when I was at Oxford, I was lucky enough to be a part of, that Louise Locock and Sue had led, was really focusing on opinion leaders and recognizing that often trusted leaders within a field will have a great role to play in terms of determining whether interventions are likely to spread or potentially if we want to try and reduce care. So again, the reason why I bring this up is because from a lot of wonderful work over decades, we have learned a ton about context and how context affects implementation, how context also affects de-implementation. I mentioned just briefly another framework, which is called the EPIS framework. EPIS stands for, as you go around the circle, exploration, preparation, implementation, and sustainment, as a way of saying that when we think about implementation and we think about overdiagnosis, reducing overdiagnosis, it's a phased approach, that there's often a whole life cycle of the energies to try and improve upon our current state of diagnosis. You see in the EPIS model, which Greg Ahrens has with colleagues developed over a number of years, some of the same features that you saw in that other framework, this notion of an outer context and all of the determinants within, this notion of an inner context, and again, some of the local factors that are affecting whether efforts can, whether evidence-based interventions can be implemented. They talk about a number, again, of innovation factors and then a number of bridging factors that affect the likelihood that an intervention will be able to spread, may be contingent on whether there are intermediate implementation in general. Now, with this particular model, what you see in this cyclical process is this nice attention, not just to the initial exploration and preparation to implement something, but the implementation phase, and then increasingly important in what happens over time, what can we sustain? So I put this particular cartoon, if I could see you and I could ask well, maybe I can. I'm just looking in the chat because I see I have some help in monitoring things. So do folks in the room know what this is a cartoon of? I'll just pause and see. So from 1963 to 1970. Okay, thank you. The Beatles, exactly. So I put this up because I think what's endemic to our system is this notion of ongoing change. And yet too often we think about sustainment as trying to preserve the initial condition, the initial test, the initial intervention over time. But as we learn from the experience, from my experience of tracking the Beatles over their career and appreciating all that they produced, is that something was learned along the way, that there were improvements made. If you just look at the haircuts, you look at the necessary eyewear, but more importantly, for me, you look at the music, the complexity of what they learned over time. And most of us who have listened to the Beatles might suggest that over time they got better, they figured things out. And yet, too often, when we think about implementation, when we think about de-implementation, we're assuming that the conditions on the ground are going to stay exactly the same. If we move away from that, then we start to think about sustainment, not about preserving the exact circumstances that we found in that initial state, but trying to think about how things evolve. And how do we confront overdiagnosis when so many things within our context and within the evidence that we use are evolving? By the way, the evolution of the Beatles' hair, if you want to see this particular cartoon. I mention all of this because we want to think a little bit differently about implementation, about de-implementation, about diagnosis, about reducing overdiagnosis, in that we need to be expecting dynamism over time. So rather than thinking about how we often want to change things around a particular intervention, what we proposed, I guess it's 12 years ago now, was that maybe we should be thinking about sustainment as this negotiated fit between our interventions, our tests, et cetera, and the context in which they're best used. And rather than assuming that we know everything that we need to know and now we just need to apply it within different contexts, how might we think differently about the coevolution of circumstances on the ground? How do we try and improve quality over time? How do we recognize that there are different drivers to overdiagnosis in different settings and over time? And if we don't try to assume that everything is sort of separate, the intervention itself is king, then maybe we'll be better off. Now, I mention this because I think it sets up, when I think about implementation or de-implementation in this case, I think it sets up a number of different actions that we need to be focusing on if we're going to try to improve care. A few years ago, Barry Kramer, who I know has been a mainstay of this conference and helped pave the way for me to join you today, he, along with Wynn Norton from my team, and I tried to think about a better way to unpack de-implementation, with this idea that this may have some implications for diagnosis as well as treatment. We recognize that there are different circumstances where evidence is going to determine that a problem exists, that the magnitude of the problem, the consequences of overdiagnosis may vary, and importantly, the actions may vary. So a lot of times, in the same way that we've thought about implementation of a new intervention as being akin to flipping on a light switch, we have to think differently about de-implementation than that it's simply turning off a light switch. We need to be thinking about some of those more precise actions that are our targets of any effort to reduce overdiagnosis. And then, carrying forward from that action, we need to think about some of the more specific barriers and facilitators, and then some of the strategies by which we can improve things. And so I did just want to take a couple of minutes and give an example of some of these actions varying by the types of diagnostic tests, screening, et cetera, that we may be confronting. So, certainly there are efforts that we need to engage in, not necessarily to get rid of something altogether, but to reduce its use. I know within my family, within many families, we have experienced healthcare where it seems like the logical next step is simply just get another X-ray. We've had in our family hip issues and knee issues and shoulder issues and back issues. And too often the idea is that an individual provider has said to us, well, best thing to do first is get an X-ray. Actually, that one's not conclusive, or unfortunately, we X-rayed the wrong part. So we're going to go back and do it again. Now, individually, an X-ray may not be tremendously harmful, but in aggregate, we start to see the consequences of continuing to rely on that as our challenge, or as the solution to any questionable orthopedic issue that we may have. And so in this case, we're not necessarily saying that X-rays are without value as a diagnostic tool, but simply we need to try and figure out whether there is a more rational way of trying to reduce the use of them. So that's an example of reduction. Replacement, we have certainly had improvements over time in our ability to best screen and diagnose. From my world at the National Cancer Institute, we've seen a lot of progress with cervical cancer screening. We've certainly seen the more traditional method of screening, the modality, the Pap test. But more recently, we've seen the incredible insights around so much of cervical cancer being caused by the HPV vaccine. And then we've seen this steady evolution of recognizing that HPV testing can potentially be a more precise way that we can diagnose, and in some cases reduce overdiagnosis, inappropriate diagnosis of cervical cancer. So in this case, we're not just talking about getting rid of something, we're talking about replacing something with another, which happens a lot within implementation, but too often within our implementation efforts, we assume that there's nothing going on before the diagnostic test that we're trying to use. So the conditions on the ground are going to vary if there's already an existing practice that we're trying to change versus there isn't a diagnostic method and all of a sudden we have a new one. So just another action that we need to be thinking about. There's other actions that we need to take, which may be around restricting the use of diagnostic methods or interventions or removing them altogether. In the breast cancer space, I know John had mentioned this earlier, that we have an estimated 14% of overdiagnosis for breast cancer. And often that comes down to identifying cancerous cells that are not likely to progress into a more extensive cancer, DCIS, ductal carcinoma in situ. And so some of our funded investigators within the breast cancer screening consortium have recognized that there may be advantages to restricting the use of or the inclusion of DCIS as a candidate to then move on to biopsies because the harms may outweigh the benefits. Again, it's not to say that mammographies have any less value than they did before, but that mammography to biopsy transition may not always be in the service of the people who are being treated. And so again, it's in some cases you might say, well, this is removing the use of biopsies for this segment of the population. In other cases, you may say, well, it's restricting the use. In either case, this is different from this idea that we are replacing something with something else. Another example of this sort of removal restriction notion comes in, and it was mentioned before, the potential overdiagnosis or the known overdiagnosis in some cases of prostate cancer and the use of PSA testing as an indicator of prostate cancer. Well, guidelines have now suggested, the current guidelines for the U.S. Preventive Services Task Force have suggested that that PSA testing is not necessarily appropriate for the general population. And in fact, shared decision-making is necessary to determine how might it be restricted so that it is not overused, and then so that the potential consequences of overdiagnosis are not felt by patients who otherwise would actually be doing okay without it. So with all of these actions, it sets up this challenge to think differently about what the roots are for overdiagnosis and then what the actions are. When we think about efforts to de-implement low-value interventions, it's important to think back to that cascade of actions that need to take place. If we have an intent to do less of something, that intent is only going to be so good as whether it is adopted within our different systems of care, whether providers are actually trained and supported to be able to do less, whether those trained providers are able to incorporate less into their practice, whether it hits the right people. I mentioned that 17-year, 14% factoid of how little we get overall, the evidence that we've generated into care. There was a third number there, which was the threshold for success. The threshold for success for 17 years to turn 14% of original research to the benefit of patient care, at least back in 2000, was that we got to 50% uptake, meaning we are just as likely to receive an evidence-based intervention as we were not to. And when we put this same kind of 50% threshold on each and every one of these stages, we realize that our de-implementation efforts, our reduction of overdiagnosis efforts, are going to decline greatly in benefit if we don't do well at each and every one of these steps. But it's not just focusing on the diagnostic method, it's really thinking about that broader system of care that may need to be de-implemented, right? So we need to ask the question for any effort to reduce diagnosis, what is the intervention? Are we just talking about that diagnostic test? Or are we recognizing that it's that whole cascade from diagnosis to the way in which that information is processed and disseminated, to the way in which we choose monitoring or follow-up actions, to the way in which we think about preventive care, treatment, all of the above. So rather than what we sometimes do is just isolating on a piece of the process, to what degree are we mindful of the various sequential steps that are going to ultimately lead to either improvements or declines in the care that we're trying to provide. Just very quickly, want to mention that over the last 15, 20 years, there's been a nice effort by investigators who've been thinking about how do we consolidate all of the different implementation strategies that people are studying, testing, developing into different buckets. I mentioned a few of these buckets up front with that infographic, but all of these strategies which we think about for implementation may also be useful as we think about de-implementation, as we think about reduction of overdiagnosis. In fact, there have been efforts to say to what degree do all of these strategies, which were developed into what's called the ERIC list of strategies by Byron Powell, Tom Waltz, and others, to what degree have those already been used for de-implementation, for reduction of overtreatment, overdiagnosis, et cetera? And so we've already seen that about half of those strategies have been used in our studies of de-implementation, but there's an awful lot more that we need to do in order to make more progress. Last thing I'll say is that Wynne Norton, who I mentioned before, and I tried to think about just some of the types of research questions that we need to be thinking about if we're confronting de-implementation, and I would think that many of these are going to be relevant for overdiagnosis as well. Are simpler interventions or simpler diagnostic tests easier to de-implement than more complex ones? What are some of the common misperceptions about de-implementation among patients, among providers, et cetera? What might differ between health professionals who don't think about malpractice, who aren't concerned about the under-treatment, recognition from those who are. And then moving forward, as we think about the types of actions that govern our efforts to reduce unnecessary care, there are some key questions that we might be thinking about, whether we're simply removing an intervention altogether, a diagnostic test, or whether we're replacing, reducing, restricting its use. And so we tried to talk about some of these types of research questions that may be helpful to interrogate over time. So with that, I just want to say thank you so much. As I said, I wish I was in the room. There's a guitar playing cat. I will say that if anybody wants to follow up, be delighted to continue the conversation over email, continue the conversation over the phone with a 001 in front of it, but happy to turn my attention back and see how much I can participate in the Q&A. So thank you very much.